Good evening, everyone, and thank you so much for joining us this evening for our monthly caregiver support group. I'm so glad that you are all here today. This space is really created for us to provide support and understanding, and for you to share your experience and have a safe space where you're comfortable talking about things and getting insights from us. We know that caring for a loved one living with Alzheimer's can be both rewarding and challenging as well, especially during those late afternoons and evening hours when sundowning occur. Today's topic, coping with sundowning, practical tips and support for dementia caregivers, will be led by our guest speaker, my friend and my neighbor, Dr. Kirk Christie. He is a respected psychiatrist who brings valuable insight and practical strategies for managing sundowning with compassion and understanding. We're going to take some time to explore what sundowning looks like, what may trigger it, and ways to create a sense of calm for both you and your loved one with dementia. You'll also have an opportunity to share your experiences. We really, truly encourage you to ask questions and to learn from each other and to share. Remember, you are not in this journey alone. Each of us is here to listen, to learn, and support one another. So let's take a deep breath, settle in, and join Dr. Christie as he begins today's discussion on coping with sundowning. Dr. Christie, thank you for your time this evening and for all of the insights and expertise you'll be sharing with us.
Good evening, everyone. It's a pleasure of mine to present for a short while on coping with sundowning. And we will be looking at primarily tips for primary care persons and also even family members, and offering them support in the care of their loved one who may be suffering with dementia. So I'm just going to move the... When we look at healthcare, I think we have to look at it holistically. And certainly I work at the Sundowning Rehabilitation Center here in Nassau, Bahamas. And we are changing our outlook of how we approach healthcare. And certainly we have to look at it holistically. And at the Sundowning Rehabilitation Center, we have a multidisciplinary team approach when we are dealing with persons who may be suffering with psychiatric disorders, inclusive of neurocognitive disorders such as dementia and other psychiatric disorders such as depression, psychosis, and drug use disorders. But I feel as if that with being empowered, we're able to make a difference in each other's lives, and we really need to be deliberate in the care of our mental health and also physical health. Today, I'm going to talk to you for a short while on sundowning. And sundowning is a term that is used to describe in persons who may be diagnosed with dementia disorder and who may not be diagnosed, but persons may be seeing episodes of confusion, agitation, anxiety symptoms, restlessness, or disorientation that occurs in persons as daylight fades into dusk and into the night. And these symptoms have its onset during this period of time and can pose challenges to caregivers and also family members. The scientific term for sundowning is now being included in a behavioral psychological symptom disorder that is clearly elucidated by psychiatrists, and it is the scientific term for the aforementioned constellation of symptoms. For today's presentation, some of the key features of sundowning include increased confusion or memory difficulties in the late day, episodes of agitation or marked irritability in the person who is suffering with dementia. There also could be what is termed psychomotor agitation, where the person may be pacing, they may be restless, and unable to sit down, and they may be shouting, they may be yelling, they may be trying to leave the residence or wander off into the yard, and they may be yelling at their loved ones or the caregiver. There also may be resistance to care or difficulty following instructions given by the caregiver and those family members who may be acting as caregivers or carers. Coupled with sleep disturbances such as initiation insomnia, the person, as the day progresses and the evening and coming into nighttime, the person with dementia may have difficulty falling off to sleep, and this is called initiation insomnia. And in some instances, persons are able to get off to sleep, but they have problems maintaining the sleep in the middle of the morning, and this is called middle insomnia. Today, we're going to we already looked at the definition of sundowning, and we know that is also termed the behavioral psychological symptom disorder. And that's just a big term, but for those who are research-led, the behavioral psychological symptom disorder is that scientific term that you should be aware of. Today, we'll talk a little bit about the role of caregivers in talking with their family members, and also if their family members serving as caregivers, some of the tips that can help them, non-pharmacological tips in managing the behavioral symptoms when they arise. We'll look at some of the medical causes of behavioral psychological symptom disorder, and so there are certain signs and certain symptoms that the patient may be presenting that the caregiver should not be dismissive of and should report immediately to the family, and the family should report those symptoms immediately to the primary care physician, especially if there's acute onset of these sundowning symptoms, coupled with impairment of vital signs, if there is fever, if there's a loss of lucidity, which is consciousness in the patient, a loss of clear and understandable language. These are signs that persons should not be dismissive of. And I'll just have a few tips for caregivers that you can use. We'll speak a little bit about a DICE regime, which involves the primary care physician if the carer is seeing certain signs and symptoms that are worrisome, or the frequency of the symptoms are evolving and to a point where the person is distressed. Dementia, it's a neurocognitive disorder described by the Diagnostic and Statistical Manual, and this is the Bible of psychiatry. It, so to speak, it has clearly defined criteria that psychiatrists refer to that make the classification, that classifies dementia and also gives the major and minor criteria. But in previous symposiums, we know and we learned that is a chronic progressive neurocognitive disorder for which there's no cure. And so the symptoms of dementia can be managed through non-pharmacological methods, through pharmacological methods, and certainly also by addressing other comorbid medical disorders which may be present. And we know that a lot of persons who enter the sixth decade of life into the seventh and eighth decade of life will also have comorbid medical disorders which need to be addressed in addition to dementia disorders. And so we know with dementia, there are problems with memory, secondarily, problems with language, thirdly, visual spatial problems, fourthly, decreased problem solving, abstraction, and other executive functionings, reduced attention, decreased ability to recognize faces, objects, etc., and decreased ability to perform complex tasks. And there's a loss of functional impairment in the persons in their arenas of life, in their occupational, religious, spiritual, and academic arena of life. This is just a slide that tells us a little bit about the type of dementia in the United States of America. and this is by way of evidence, is referenced at the bottom, but we know that in 62% of patients who develop neurocognitive disorder, the Alzheimer's disease is the most prevalent, followed by vascular dementia, and to a lesser extent, the frontotemporal dementia. We have other type of dementia caused by alcohol, chronic alcoholism, and two other types of dementia can be caused by traumatic brain injury for persons who may have sustained blunt force head trauma in motor vehicle accidents, or even gunshot wounds. Moving on, it's very important for families and carers to understand the staging of Alzheimer's disease. And I think it will help a lot of families if you know the stage, the clinical dementia rating scale. And we know that, you know, there is a clinical rating score, and we know it ranges from 0.5 to 3. So associated with the mild cognitive impairment 0.5, there are apparent cognitive changes stated here in this category, mild problems with memory or other cognitive domains with objective deficits on testing, no problem with orientation. And functional changes, there's no significant decline, and there is some slight impairment in community affairs and hobbies. But as we move into moderate and the severe classification, which are the CDR2 and CDR3, we can see the increase of more cognitive symptoms and more impairment, especially if you look at the classification of 3, CDR3, there's major neurocognitive disorder, severe. If you look at the cognitive changes category, there will be severe memory loss. Persons may be only oriented to person, unable and not to place and not to time, and they may be unable to make judgments or solve problems. There are also functional changes, and with activities of daily living, they may need full supervision in terms of bathing, feeding themselves, toileting, and being able to do like comb their hair, wash their face, brush their teeth. So there will be a need for more assistance with activities of daily living when it comes to the severe Alzheimer's disease. And talking about what we discussed earlier with some of these symptoms of the behavioral psychological symptom disorder, also loosely referred to as Sundowning, we can see some of the symptoms that appear when persons are diagnosed with dementia. Apathy is there in 49% in terms of the prevalence among persons diagnosed with dementia. We have depression. There may be episodes of aggression, sleep disorder, and these are rank and file in terms of their prevalence. And so as you go down the list, then there is a decline. You have some of the thought content abnormalities with hallucinations at 16%. And there also could be the thought process and also with delusions, false fixed beliefs at 31%. The point I'm making is that there is a constellation of symptoms which accompany the Alzheimer's disorder. And this graph just depicts that some of the symptoms of the behavioral psychological symptom disorder, which appear with the mild disorder or neurocognitive disorder, the moderate, and in the severe. So I just want to draw your attention to the moderate. We can see the preponderance, that's CDR2, of delusions, which are thought content abnormalities. We see that there are also mood disturbances, which are evident. Also hallucinations, which are perceptual abnormalities, anxiety, apathy, and agitation, which can occur. And so you could take your time to look at this slide. I will make it available. So you could identify other symptoms related to severe illness. The causes of dementia, it is important to understand, and it's a clinical diagnosis during the course for individuals, but you won't be sure of the diagnosis until after the person demise, where studies can be done on the brain to assess macroscopically any changes that are present in the brain. But clinicians can make clinical diagnosis on what they feel based on the presence of behavioral and psychological symptoms. And right now, for looking at this graph, you can see Alzheimer's disease with mild dementia. As we saw in the earlier slide, the presence of depression, anxiety, insomnia, and in moderate to severe illness, hallucinations, delusions, repetitive and aggressiveness. And with vascular dementia, this is seen in persons with long-standing high blood pressure and also diabetes. There are the presence of apathy, the lack of motivation, and also depression symptoms. And so we have with other causes of dementia, frontotemporal dementia, there may be aggression, apathy, and disinhibited behavior seen. Caregivers play a very important role in the management of persons who are diagnosed with dementia disorders. And they are often the persons who are entrusted by family members to take care of their loved ones for prolonged periods of time. And so it is very important for caregivers to understand what's happening with the person whom they're caring for. If they see any of the sundowning symptoms and they are not progressing, they're not distressing to the patient, then certain non-pharmacological behavioral management can happen. But if they see the symptoms are distressing to the patient, and if you see there's a risk of death or mortality as it relates to the patient, where the person may do something to harm themselves or cause danger to themselves and to others, the caregiver has a role to inform the legal guardian or the decision maker as it relates to the patient. And so what is very important is for the caregiver to understand the onset of these symptoms, which we have mentioned in terms of agitation, where there's irritability, where the person is refusing food or refusing water. It should be reported, especially and documented, the onset of the symptoms, the frequency of the symptoms, and when it occurs, how long does it last, so that information can be shared with the family or the legal guardian or the person who has the enduring power of attorney over the individual. And so how should caregivers respond? They should respond in a manner that shows empathy and shows support to the patient, and they should be able to de-escalate the situation when it occurs. And so caregivers need training. It's very important for caregivers to learn about sundowning or the behavioral psychological symptom disorder. And if the symptoms are acute in onset and the caregiver has not seen these symptoms before, it could be a sign of a medical cause or an acute medical condition. So it should not be dismissed. And certainly if the carer also sees impaired vital signs, an increase in blood pressure, or an increase in pulse rate, or even a fever, the caregiver should report immediately to the family, and a call should be made to the clinician, giving a brief summary of the acute onset of the symptoms, because it could be a medical cause, which can be a medical emergency. And so the caregiver has a very important role of deciphering some of the behavior which we've spoken to earlier. Now, the assessment of the behavioral psychological symptom disorder, I included a slide to just make the point that if the symptoms are very distressing to the patient, and if the caregiver feels that the behavior can lead to harm and or death, the caregiver must report to the family. A call must be made immediately to the primary caregiver so that a discussion can be had, and certainly screening can be done at the polyclinic or at the private office. And so one should not be dismissive if these symptoms are very distressing. If the patient poses a risk of harm to themselves and to others in terms of marked irritability, the agitation is escalating to chaotic behavior, where the person may be becoming violent and or markedly aggressive. This should not be dismissed. A phone call should be made immediately to the primary care physician, and action should be taken to transport or facilitate the transport of the person to the clinic or to the emergency room for a thorough evaluation. And some of the medical causes include, and we've learned this in previous symposiums, that it could be electrolyte abnormalities, it could be high or low blood sugar, it could be dehydration, there could be some issues with liver disease or even hormonal problems, such in cases of hypothyroidism or hyperthyroidism. So there are different things that can be going on metabolically in patients suffering with dementia disorders. Secondly, infectious causes, such as in instances of urinary tract infection, meningitis. And certainly, there could be cases of stroke that persons can lose lucidity in terms of being able to express themselves clearly and understandably. And so if there's a loss of consciousness, this should not be dismissed. And persons should inform the primary caregiver immediately, whether it be the family or the guardian, the legal guardian, immediately, so that a call can go through to the primary care physician or even facilitate the transport of that person to the emergency room for urgent care. And we learned in a previous lecture, a symposium about pain. I had mentioned before that sometimes persons acting out, they may be in pain. And we know that a lot of persons who are diagnosed with dementia may not be able to express themselves appropriately and may be being diagnosed with osteoarthritis and even dealing with other trauma from past decades, whether it be motor vehicle accidents or falls. And it's very important for the caregiver to elucidate whether or not the patient is experiencing any pain. And pain may be a trigger for odd behavior, whether it be moaning, groaning, also the loss of lucid periods. The patient may be overwhelmed with pain. And so there is a score, a ratings tool that the caregiver can ask the person between the level of 0 and 10, 1 being the best the pain could be, and 10 being the worst. What number would you give it? And this is a objective way of looking at the intensity of the pain. Now, in severe dementia, the person may not be able to respond in light of the cognitive impairment. But if you see the person guarding, if they're holding their abdomen, if they're holding their shoulder, if they seem to be moaning and groaning, this should not be dismissed. And certainly the person should be taken to the critical care for urgent evaluation to rule out any fracture, dislocation. So pain is very important as it relates to the person who is diagnosed with dementia. When you're looking at symptoms that are distressing and moving in to cause morbidity and mortality in the person, you have to consider, are medications the cause of the sundowning or the behavioral psychological symptom disorder? And we know that medication can cause certain type of behavior in elders who may be diagnosed with dementia disorder. And these are some of the classes of medication that can cause drug-to-drug interactions and also can cause noxious side effects, whether it be sedation. It can also, some of these medications can cause psychosis, especially steroid medications can bring on psychosis and paranoia. And so we have to be mindful if you see the loss of lucid periods, if you see the evolution of the sundowning symptoms, a word has to be um, to document it, the summary of the behavior, and a conference with the primary care physician should happen immediately to update them on the behavior seen. The primary care physician will do an audit of the medications. And like I said, some of the obvious culprits are right here that can cause drug-to-drug interactions and undesirable side effects. All right, I have, and I know time is going, but I just wanted to say for our caregivers, I'll just offer some of the non-pharmacological tips. And there's some that they're categorized as environmental strategies, and I came across several of them, and I'll just give you several. And under environmental strategies, it is very important for the caregiver to keep daily activities and bedtime consistent to reduce confusion and anxiety. And secondly, to optimize lighting, to increase indoor lighting in the late afternoon and early evening to reduce shadows and to help maintain the person who is diagnosed with dementia disorder so that they can be oriented to time. Also exposing the person to bright light, especially in the morning or early afternoon, can help with their mood and to help to normalize the sleep-wake cycle, which is the circadian rhythm. It's very important that the carer reduce noise and overstimulation of the patient. So keep the environment calm in the evening, lower the television volume, avoid loud conversations around the person who is diagnosed with dementia, and minimize visitors in the evening. And it is very important to have familiar surroundings, to offer familiar surroundings to the person. So use familiar objects such as photographs and furniture to promote comfort and reduce disorientation in the person. Behavioral and lifestyle measures, I would just mention a couple of them. Encourage daytime activity for the person whom you're caring for. Gentle exercise or engagement during the day helps promote nighttime sleep and reduce restlessness. And avoid the person having too many daytime naps. This can interfere with the normal sleep pattern. So limit the daytime nap to about one daytime nap in the early afternoon. And moving on, simplify evening tasks, keep evening routines quiet and soothing, listen to calm music, reading or gentle conversation with the person is very important. And avoid the person having caffeine, nicotine, and alcohol. These should not be given to the person with dementia disorder. Caffeine is a stimulant, and it can interfere with the normal sleep-wake cycle. And always endeavor to provide comfort and reassurance to the patient or to the person under your care. Stay calm, speak softly, and offer reassurance if the patient becomes agitated or fearful. And as far as the medical and clinical management, as I said before, if you see the symptoms of sundowning or the behavioral psychological symptom disorder evolving and they become very distressing to the patient, and further, if you see that the patient's behavior is moving to a point where they can cause grievous harm to themselves and to others, then you need to report it immediately to the guardian or the person who has the enduring power of attorney or the surrogate decision maker so that you update them on the onset of the symptom, the frequency of the symptom, the intensity of the symptoms, and what has been happening. And you just prompt them to have a call with the primary care physician for guidance, because this may mean that there could be possibly an underlying medical cause for the acute onset of these symptoms. There also could be medication effects such as drug-to-drug interactions, and it could also be stroke. You know, sometimes persons who are diagnosed with high blood pressure and even diabetes may also suffer with stroke, and these symptoms may present atypically in the elder patient. Now, we're not going to talk about medications today, but medications are given on a non-emergency basis if the symptoms are evolving, if the symptoms are very distressing to the patient, if they're causing, if the patient is at harm, then medications can be given. And this is a discussion that would happen with the primary care physician or gerontologist or geriatric specialist. And some of the typical medications that are given for depression and anxiety are a selective serotonin reuptake inhibitor. We did talk about those in previous lectures. And for insomnia, we can use trazodone. Psychosis or agitation, we have the atypical antipsychotics can be used to diminish and ameliorate psychotic symptoms such as delusional thinking and hallucinations. Risperidone is one of them, olanzapine, and aripiprazole. And before any medication is given, the physician would seek informed consent, would discuss the potential benefit and risks with the family, whether it be the guardian, the surrogate decision maker, or other family member. And physicians, we always discuss the benefits of giving medication and certainly the common and rare side effect of medications. And this is done at every turn. And so this is a scientific approach, and some of it was covered about describing. So the caregiver is involved in describing the symptoms of sundowning or the behavioral psychological symptom disorder, the onset of symptoms, the frequency, the intensity of symptoms. And it's very important for the carer to report to the family member or the primary caregiver. The investigation is done by the clinician, and so it's the role of the physician to rule out medication effect or an underlying medical cause for the changes in behavior. And there's always a collaboration between the physician and the carer and the person who is in charge of all decision making in order to strategize behavioral interventions. And there's always an evaluation that is done, follow-up and assessment, and assurance that the patient is responding well to the treatment regime. And so I just want to iterate the importance of all stakeholders. And I just want to say at this juncture that caregiver burnout is real, and it's very important for the primary caregiver, whether it be a family member or a hired caregiver, to have breaks, to ensure that they're having lunch, that they're eating appropriately, because there's a lot on their plate, surveilling the person with dementia disorder, and caregiver burnout is real. And so it's very important for the caregiver to have some days off, and also to be relieved by another caregiver if it is possible. But certainly take your breaks, continue to deal with the patient in an empathic way, and also read about sundowning and behavioral psychological symptom disorder. It's very important for our carers to read about it and to know a little more about it. And whenever you are in doubt, always consult. If there's a symptom that you're seeing and it was not there before, and the patient seems to be very distressed, always report. Never withhold any information from the family or the primary caregiver of the person. And so by way of research, as I mentioned earlier, some of the caregiver tips, it is the most effective interventions for persons with dementia disorder include the maintenance of structured activities. And surprisingly, music therapy is found to be very, very meaningful for persons with dementia. Also, reminiscence therapy, where photographs of previous events can be pulled out from past years or past decades, and the carer or the family member can ask the person to remember faces and remember the event of past celebrations or past experiences. And certainly Board games such as Scrabble, wordplay are very important. Sudoku, if the person is in moderate or even mild dementia and is able to do board games, is very important. These games can help them in terms of preserving their cognition. The most effective intervention for families is supporting family caregivers, and this is by way of the body of research. And the most effective intervention for facilities are training programs for formal caregivers. At the Sundowning Rehabilitation Center, we have ongoing training and certainly a robust training program for all levels of staff, and is very important. The more knowledge we have, then we can apply this knowledge and implement the knowledge. And dementia care mapping or other quality improvement tools, very important for the care persons with dementia disorders. All right, so it brings me to the end of today's presentation. I just wanted to give a little summary. Sundowning refers to increased confusion, agitation, anxiety, restlessness, or disorientation that occurs during dusk, well, the late afternoon into the dusk period in persons with dementia. The behavioral psychological symptom disorder is a scientific term for the constellation of symptoms in dementia patients. The severity of dementia disorder can predict what behavioral psychological symptom disorder symptoms will be apparent in the person diagnosed. So it's very important, I think, for families to know the severity of the underlying dementia disorder, whether it's mild, moderate, or severe. And the behavioral psychological symptom disorder symptoms which appear acutely in the person with dementia should not be ignored, and a medical cause should be ruled out. And so it's very important for the caregivers to report to the principal caregiver or the family representative. Caregivers play a critical role in describing the sundowning symptoms or behavioral psychological symptom disorder to clinicians, and play a role in the acute management of these symptoms, as we saw by way of certain interventions. Thank you for your time and attention, and I will entertain any questions.
Thank you so much, Dr. Christie. A lot of fantastic information. I do want to, before we open it up for questions, Dr. Crystal, you are on the line. She is our co-host. Dr. Crystal, do you have any thoughts about or anything addition you want to add to Dr. Christie's presentation?
Hi, Mr. Vole. Hi, everyone. No, I thought it was very comprehensive, very well put. So I thoroughly enjoyed it, and I hope that everybody learned more things the way that I did tonight. Thank you so much, Dr. Christie.
It's my pleasure. My pleasure.
Dr. Christie, there's the button up top. If you want to just stop share.
Okay. Yes.
Stop share. Dr. Christie did a phenomenal job, as Dr. Roll said, comprehensive. We want to open it up for questions. Do you have any questions for Dr. Christie? Remember, Dr. Christie is the expert. He's a psychiatrist, and he sees a lot of patients. He works in the public sector. Did say, Dr. Christie, that you're at Sundowning Rehabilitation Center. So this is what Dr. Christie does every day. Do you have any questions for him or any thoughts, comments? So Dr. Christie is talking about sundowning. All of you on the call in some way are affiliated with someone that has Alzheimer's or dementia, or you may be a caregiver. Does any of your family members have sundowning, or maybe you're not sure? Do you see any of these symptoms that Dr. Christie was talking about in his presentation?
Hello, good evening. Christine here.
Hi.
Hi. My mom, she has been through that stage, and I believe she's over it. What Dr. Christie said, it was very clear and understood, and some of the things that he mentioned, she had them and I didn't know at the time, but when I found out, I do things differently. And I thank God for this presentation, and I thank God that my mom is out of that stage now. she is more on the quiet side. She don't move around anymore. She's like bedbound now. But sometimes I notice she get a little restless, and I study her like how like a little baby, you have to think for the baby. So that's what I have to be doing for her now. So whenever she's restless, I will check to see if she's wet or she need water or whatever. And most of the time, it always works. It's either she wants to sleep, want water, or she's wet or something. So yes, I thank God, and I thank you for this presentation, Dr. Christie. That's all I have to say. God bless you all, and thank you for this beautiful program. I've learned a lot.
Fantastic. Thank you so much for sharing your comments and thoughts there, Christine. We do
You're
appreciate
welcome.
Dr. Christie, any comments about that? Because I do have, she said that her mother is through this right now. I think that's amazing. How does that happen, Dr. Christie, and when does that happen?
Yeah, it's a very difficult process, especially for family members to see the cognitive changes in their loved one, and certainly having to pursue legal guardianship or the enduring power of attorney, even that may be troublesome as well, and certainly costly. But certainly there's a human side of it as it relates to caring. And I just want to mention caregiver burnout to emphasize that it is real. And a lot of families are dealing with caregiver burnout, the loss of motivation for caring, and the lack of just the resilience when dealing with their loved ones. And so it is very important for carers to take some time out for themselves to recover from the shifts, especially if they're working 8-hour shifts, to be able to recover from those shifts, to be given some time off, especially on the weekend, to recover, because there's a lot at stake. And certainly during the period of caring, you have to surveil the patient. You have to be mindful of the administration of medication. It can be taxing on the person who is caring. And certainly you have to be careful of the person wandering off from the home or elopement from the facility. All of that, it can be very stressful to the carer. And so there's a lot on the plate of the caregiver or the family member who's caring for their loved one. So I just want to encourage everyone who's doing it and not to give up, and continue to show empathy. I know it can be difficult when persons are in that state of sundowning, but remember, it's not their fault. It's due to the process, the changes in the brain, especially with the cognitive changes and a structural level. There are changes in the brain, and it's not the patient's fault that they want to be carrying on if they're agitated or they are being irritable. It could also be depression, and sometimes persons need to be assessed by their clinician and prescribed an antidepressant. There are many persons with dementia who are depressed, and so they themselves have a lack of motivation. Their mood is in the low spirited or the low pole of the mood, so they may not be agreeable when they're dealing with their family members. So depression is real, and it also can cause the person to be not motivated, and also being unable to make decisions for themselves in the state of mild dementia and moderate dementia.
Thank you so much, Dr. Christie. I have a question for the group. Has anyone noticed any changes in their loved one's mood or behavior in the afternoon or early evening, like Dr. Christie said? Has anyone been? Hi, go ahead.
Good night, everyone.
Hi.
Well, I take care of my mother. She is 80. And yes, in the evening, I did realize that she changes her whole being because she looks for people that are not there. And then sometimes she gets angry with me or my dad because she say they were just here. And we told her no. And then sometimes we have to go with her story But you know, she gets irritated when she asks you the name of the person and you're trying to go with the story, and when you start calling names, she's like, no, no, not that person, but you just saw them, you know. And it's very disheartening and hurtful to see them deteriorate like this, you know, especially for my dad, because I actually work day and night, you know. So whenever I could give him relief, I try to, but he is even older than her, and it's really, really taking a toll on him. So, you know, I feel so bad for him sometimes. And like this week, I'm taking a vacation because I say I need a break. But I really feel bad leaving him alone there with her, because I do all of the cooking and I do everything for her. So I, in turn, have to make sure that somebody will be there, not even live with them, but just to go there, because I don't have to physically wipe her up or anything, because she can do that for herself, you know. But caretakers really need someone to take care of them sometimes, because I can see the depression sometimes in him. And when it first started, I used to get depressed. I used to cry a lot because I'm like, this is not my mother, and I just don't know how to deal with it. But as I learn her behavior and learn her attitude, I can better deal with it. So it's just a part of my day-to-day routine. But nobody else understands that. So when Dr. Christie said to limit the people in the evenings, I have already done that, even sometimes through the day, because people don't understand what they are going through, and they start the repetitive question, you know, then they won't understand what's going on. And you don't want people to be insulted by them, as well as you don't want your loved one to be hurt by what someone else is saying. So we try to limit, well, not so much strangers, but from people from coming around. And maybe the very, very close ones, you will allow them to come, have a word with her, tell old stories, because that's all they remember, you know. So all I can tell everyone is continue to love them and continue to be patient and do the best that you can. Thank you.
Thank you so much for sharing that, Monique. That is very, very inspiring to hear you say that. And also, it helps to hear someone because you sound young. You know, you said a few things that were so important, and it also reiterated what Dr. Christie said. You said about you're going through, you need a vacation because you feel burnt out. You need to take a break. Your dad has gone through depression. Your dad needs a break. So Dr. Christie said caregiver burnout is real. And I know for a fact that it is, because 30% of caregivers die before the person that they are taking care of. That is why it is incredibly important to get to help your dad, to have your dad help you, get another family member to come and help, so everyone has a little break, because everyone needs a little break sometime, so that you don't get burnt out. Your dad doesn't get burnt out, because you don't want it to be, you don't want to be in a situation where now your dad is sick. Now you have to take care of both of your parents. So think about friends, old friends, family members that may come, even if it's just a couple of hours, you know, a few days a week, to help you and support your dad. That would be great. Dr. Christie, Dr. Roll, any other thoughts or comments on that?
And what I'd like to say is also, if you are seeing major depression symptoms in your loved one, you can report these symptoms to your primary care physician, who would do a screening. And there are certain screening instruments known as the Patient Health Questionnaire 9 or the Beck's Depressive Inventory. And so secondary screening can be done on these persons. And if they meet the criteria of a major depressive episode, then they can be commenced on an antidepressant medication. And some of the common ones are sertraline, Zoloft, is very good for elder persons, and very tolerable medication that can help to elevate the mood of the elder. I have several elders that I have on sertraline, and they're doing very well. And so the person doesn't have to suffer in silence, nor does the caregiver. So, just simple reporting to the primary care physician and letting them know that, you're seeing this depressive symptoms like lack of enjoyment, the persistent depressed mood, the person their appetite may be down. This may be a symptom of depression. The lack of inability to make major decisions. These are also symptoms of depression and also sleep disturbances. So antidepressants are helpful with elders, and we have very good, tolerable antidepressants.
Thank you, Dr. Christie. Dr. Roll, anything else to add?
No, not at this time.
Okay. So I want to share a story, and Dr. Christie, I want to share the story and then come back and ask you this question. My mother-in-law is currently in the hospital in a inpatient rehab. She told us on Sunday when we visited her that she has 2 months lapse in memory. And she told us on Sunday she seemed 100%, actually she's about 95% there cognitively. But for about 2 months, she has a complete lapse in memory. She doesn't remember anything. And then prior to the 2 months that she talked about, we did notice that she was cognitively impaired. And we also noticed a decline in her mood in the evening hours. What precipitates someone to have a complete loss of memory for 2 months and then come back to almost 95%? Is that possible? What do you think that is?
Just, can you tell me whether or not she has had any previous episodes, loss, like amnestic episodes or loss of memory in the past? Did she have it, or this is the first time she has experienced it?
Well, she was working up until a year ago. She fell, and that
Okay.
decline. She fell and broke a hip, and it started a decline. She actually worked
Okay.
a year ago.
Okay.
She no issues.
Okay.
She does. Prior to the 2 months, she did seem to start having the beginning stages of MCI, but prior to 4 weeks ago, there was a 2-month period where she was totally gone out of it. Didn't remember anything. We don't know what happened.
Yeah, sometimes they are confounders here. Sometimes the medical disorders can also cause memory disturbances, can have an impact on memory, especially in nutritional deficiencies, and certainly the vitamin B deficiency, but also trauma. Trauma can cause some type of amnesia or depression, even something called depression or pseudo dementia symptoms. Traumatic brain injuries, traumatic falls. Certainly, that's a very serious fall because she broke her hip. So trauma can also bring on certain memory disturbances, disorientation, and repression of thoughts and memory because of trauma.
Yeah. She did. Actually, the doctor called and said she wants to go on depression medication. She feels depressed. She's anxious. You're absolutely correct. All of these things, I'm now connecting the dots as you're sharing this, Dr. Christie. So this is very, very helpful. I know that other people on this call, you might be thinking the same thing. That's why we do the support group, because every time we do this, it's like a light bulb goes off and then you connect a dot. Oh, that's what's going on. Because I just connected a dot with you, Dr. Christie, that, yeah, she did have COPD, UTI, CHF. There was a lot of issues going on. And now that they are mostly resolved, she now appears to be coming back, which is good, right?
Yes. So the medical disorders can also cause impairment in the mental status and also with the memory, the short-term memory and the long-term memory. And so she would have gotten the optimization of the management of these disorders. And so cognition can improve. We know cognition can improve by way of diet, multivitamins, and certainly management of these, whether it's hypertension or heart disease. Your memory can improve.
Wow, fantastic. Thank you so
Yes.
much.
Yes.
Any other comments? Let's see. Severe delirium. Dr. Roll, you're right. You've spoken about this before. Dr. Roll, you mentioned severe delirium seems to have been her issue. You're absolutely correct. You've said this before. Yes. I truly believe that. Any other comments here as we're talking about coping with sundowning and just the challenges that you may encounter with sundowning and with tips to help you deal with your loved one with sundowning. Any other thoughts, questions?
I just want to iterate that a person's, if their loved one is hitting or they're moving into rage, you should not be dismissive of these symptoms. So once the behavior starts evolving into dangerousness, you have to report it immediately to your primary care physician, who would do all of the screenings and the assessment. And your loved one can benefit from a mood stabilizer or an antipsychotic to curb this type of chaotic behavior. So do not suffer in silence or feel, oh, I'm ashamed of taking my loved one or reporting to the primary care physician. But if you see this type of behavior, the person is hitting, they are bruising themselves, they may even be cutting, or they may be trying to wander off from the property or elope from their residence or property, bring it immediately up to the attention of the physician. And sometimes you have to prioritize. I know it's a short period with the physician, but when you get into a conference with the clinician, you have to say, these are the priority signs and symptoms that I'm seeing in my loved one, and I'm concerned over these symptoms. And so you'll be able to tell them, hey, something has to be done regarding the behavior. And so antipsychotics can be given if it's anxiety, depression, and antidepressant. If it's the disturbed behavior or chaotic behavior, an antipsychotic, which I mentioned, can be given to curb and lessen those behaviors so that the person can return back to baseline in terms of their behavior.
Fantastic. Thank you so much, Dr. Christie. Being a caregiver is really tough, but being a caregiver takes a special person, and all of you are special. The fact that you are taking the time to be on this call, to learn more, and to care for your loved one makes you a very special person. So I want to say that I'm proud of you. I want to say this for Dr. Roll. I'm pretty sure Dr. Roll is proud of you. Pretty sure Dr. Christie, myself, and Dr. Clark were all proud of you. How do you remind yourself that you are doing your best every single day to care for your loved one? This is a question I'm throwing out. How do you remind yourself that you are doing your best? Even when it's difficult, even when you're crying. Anyone?
That's a very tough question, you know, because I never thought my best was ever good enough, because I know I'm not perfect, and I don't know when I'll be, even though Jesus wants us to be. I tried my best all the time, and it's really hard. I just do my best, and I leave the rest to God, because sometimes the things that I want to do for my mom, I don't get to do it because there's so much to do and it's only two hands. I have somebody help me 3 days for the week, but it's like for 4 or 5 hours for those time for the day. And my sons are here with me. They help me as well, like to help to lift her from bed, to cheer to bed. But I don't know. It's never enough for me, but I'm just doing my best. I'm just doing my best, and I take breaks when I can. I'm due a break now. I don't know how it's gonna happen because my sister is unable to come right now, but I do the best with what I can. Whenever the person comes in to help me, I will go on the road to do a little shopping, or if I have an appointment, or just to do something. But now it's getting cold, so I cannot go out much, but I make the best of it, the best way. And that's what I can say right now. All right.
That's just perfect.
Thank you.
You are just doing your best.
Yes, I try.
The best is what we're asking for. That's all your loved one needs. Do your best.
Yes. Thank you.
Sharing that. Does anyone else want to share? So, let's think about this. If you were to send a message to someone going through exactly what you're going through right now, what message, what words of encouragement would you share with another caregiver going through what you're going through a loved one with dementia, Sundowning? What words of encouragement would you give them? No one has any words of encouragement? No, I can't be the only one talking today. So if you're not talking today, it does mean you've had a really difficult time today. Are you burnt out? Are you tired? Do you want to give up? Talk to us. What's going on? We want this to be a safe space for you. We want this to be an opportunity for you to have that. This is your time to get it out and to talk about what you're feeling so that you can be a better caregiver for your loved one. I'm always doing the talking. I'm always talking. I'm trying to get you all to talk tonight. Dr. Roll, do you have anything else to share, to add as we wrap up? No, ma'am. Dr. Roll says, no, ma'am. I'll tell you all hilarious. Dr. Roll is at work right now. She's at work every single month we're on this call, but she dials in. Dr. Roll, we appreciate you so much. Yes, I know you're at work, Dr. Roll. We do appreciate you dialing in. Dr. Christie, we are going to wrap up this evening. Is there anything else you want to say as we close out for everyone here?
I would just like to encourage everyone who's dealing with an elder who may be diagnosed with dementia disorder, and just encourage all of you, do not give up. And there will always be unforeseen things happening in your lives, but remain positive, remain in a spirit of gratitude. It's very important every morning to state 4 things that you are grateful for. And these things can empower you, can help you. And so find 10 minutes to really to meditate and be grateful. Gratefulness can bring happiness and joy in your life. Sometimes we're wondering about the things that we do not have in terms of material wealth or things, but just really understanding that we're here, that many of us are in good health. We're still in good health. We are here despite of the financial woes, despite of our loved one having their medical disorders. But life is still precious. Life is still great. Many people are fighting for life. If you go to the hospital on a Sunday at PMH, people are dying to have a few more months or wishing that they can have a few more months on this earth. So remain in the spirit of gratitude. life is still precious, despite the many challenges and woes and crisis situations that may occur.
Thank you so much, Dr. Christie. And I know that when you're going through this journey and you're constantly running and you're constantly working, you get burnt out and you get tired. You get tired. I understand. Please, I encourage you to take some time to find someone, even if it's just for one day, to come and help. 2, 3 hours. And those 2, 3 hours that you have, don't run around. Go somewhere, go to the beach, go to sleep, read a book, do absolutely nothing. Give yourself time to relax. Listen to music, like Dr. Christie said, music therapy. Listen to music and just relax and give your brain a break and some time off. Your loved one is not always going to be here. We're not all going to be here forever. Nobody is. When your loved one is no longer here, you can't get back that moment, the time that you have right now. My mother is not here anymore. And every day on my phone, I have a picture of my mother to remind me every day that my mom is not here, but she's always going to be in my heart. So I want to encourage all of you. We talked about sundowning today, but the premise of this support group is for those of you and for those of us who are caring for someone with dementia or Alzheimer's disease. Please lean on us. Please use us as a support. We are here to support each other. We're all in the same boat. So I send you love, support, and words of encouragement this evening. If you would like to be a part of our support group on WhatsApp, please drop your phone number in the chat and we'll add you to the support group. But remember, we are here together going through this journey called life. Let's do it together. You're not alone. I want to thank Dr. Christie again. My co-host, Dr. Teresa Clark, is not here, but she'll be back next month. And I want to thank my other co-host, Dr. Crystal Rowe, for being a part and sharing her insights. Thank you all. I will see you next month. Remember, our support group is every first Tuesday of the month, 6:30 with the same link. So we'll see you next month. But if you have any questions for us, please drop it in our WhatsApp group, and we will be sure to support you in any way that we can. Have a great evening.